I'm going to present a multiple sclerosis case. A patient presented to us, she was 42 years old female, originally from the Philippines. Her history started with a sudden onset of headache. She was working as an ER nurse at the time, and because of her working setup, they immediately took a CT scan for her, which showed white matter disease. So the doctor requested further investigation with lumbar puncture and to check the cerebrospinal fluid as well as an MRI, which both have confirmed her diagnosis of MS, and this was back in 2011. When she gets the attack, she feels that she has numbness mainly in the right leg, and also she feels dizziness. Also, she sometimes feels she cannot hear in her left ear. It feels very weak and she cannot really hear in it as usual. She also feels her attacks are more common in the summer to lead to blindness temporarily in her eye. And she feels also this comes more with stress and heat, it triggers the attacks. Initially in 2012, she was managed by Lyrica, Flumig, and steroid injections, and some dietary recommendations. She said it helped a little only with the pain, but not with the other symptoms of numbness or the blindness or the ear not listening with it or hearing with it. Then the patient moved to Dubai. And in Dubai, Lyrica wasn't available over the counter. And due to her limitations with insurance and the coverage, she decided to manage her symptoms without medications. She noticed that she used to get more attacks in the Philippines in general. So she wasn't sure whether it was because she was living a very stressful life there due to the death of her mother and her divorce. Anyway, the last attack was 8 months ago since I saw her, and it stayed for 2 days where she couldn't go to work due to the leg weakness. She was diagnosed and confirmed by several MRIs that she is in a relapsing remitting stage. Her headache history, she usually gets headache 3 to 5 times a week since 3 years, more so in the afternoon. Sometimes she feels as if the eye will bulge out and her brain will explode. And it's usually throbbing associated with photophobia and phonophobia. And if she doesn't take medication, it won't get away on its own. She usually takes Voltafast for it, which helps. So this patient is almost addicted on Voltafast. She takes Voltafast really with every headache episode. She takes Voltafast. In terms of sleep history, she says that she most of the nights she sleeps very well, but she has this severe bruxism at night that's very very loud and wake up her roommates. She sometimes wear a night guard, and also she did Botox injection for the masseter every 6 months. And history of her bruxism started since she was a teenager. Again, as I said, socially, she is divorced with one child who is 17 years old. She works as a receptionist and she is happy with her work now. As I said, she takes Voltafast at least 3 times a week for the headache, and family history, her mother died with cardiac arrest. Extraoral examination showed normal head and neck exam, as well as all masticatory muscles were normal. There was no tenderness except for a little bit mild on the neck muscles. Her range of motion for opening and lateral excursion were within the normal limit. She doesn't have any clicking or any sounds in the TMJ, and the cranial exam was within normal limit. She has a history of having braces in 2011. She removed the braces in 2012, where upper fours were extracted. She has multiple missing teeth that are restored with a removable Holy retainer, as we will see in a minute. And she has a scar line in the upper lip due to previous lip surgery to reduce the gummy smile. She has redness on the palate that is non painful, can either be from the irritation of the Holy or it can be from candida. So these are her pictures with the Holy, and we can see she has upper and lower Holy. The upper one is to retain the orthodontic result, and the lower one is to restore the missing teeth. So as we can see, she has good overjet and overbite when she is wearing the Holy, versus when she's not wearing, it feels more deep in her bite, and we can see all the big edentulous spaces that are restored by this removable Howley retainer. And looking at the MRI, we can see this was an MRI back from 2013 that confirms that she has multiple diffuse subcortical and pericallosal supra atenorial white matter plaques, which means it confirms the diagnosis of the MS, which is usually confirmed with those white matter that are seen in the MRI. 3 years later, she took another MRI, and it didn't show a lot of progress compared to the previous MRI. As we can see here, it says that hypersensitivity may have slightly increased in number from previous MRI, only slightly within 3 years, so nothing major in her progression. So she's kind of remitting, relapsing, but slowly progressing. So her diagnosis would be relapsing remitting MS or medication overuse headache. I was actually very concerned with the amount of Voltafast that she was taking, and I will talk about it in the plan. And of course, she has this sleep bruxism that's very, very loud. So my plan was first, it seems that the patient is coping well with the MS, except for the headache issue. So it's been since 4 years now since she took the last MRI. Reason being that she can't afford it, or I think her insurance privileges has changed and she cannot afford taking an MRI again. It would be ideal for her to see a neurologist again and get a new MRI, and maybe if she can afford also to consider the disease modifying treatments, the new ones that are used now for MS, if she can afford it. But again, she said with the insurance it doesn't cover, and she cannot consider these medications. In terms of the medication overuse headache, I sat with her and I explained to her that she is stuck within this loop of taking Voltafast for the headache, and then that makes her more addicted to it and cause her what we call medication overuse headache, and that she needs to really seriously consider to detox herself from those NSAIDs, and maybe consult with her neurologist to see how we can help her during that detox period, maybe with prescribing Topamax until she can get out of this addiction. In regards to the bruxism, the things that she already has a splint, and she knows that it doesn't stop her from bruxism. It maybe can protect the Holy or her teeth. And she already tried the Botox, and she knows that it helps, but she cannot afford keep taking it every 6 months. So what I was left with is actually just to recommend for her to have CBT therapy, to probably clear out all the internal stresses and anxiety that she has that might be contributing to this bruxism behavior that she has. In terms of the palatal irritation, it depends. If it wasn't due to the physical irritation of the Holy, then I will educate the patient how to keep the Holy clean and to soak it with chlorhexidine and to try to sleep without it if she can. If that doesn't help for a while, then maybe we can prescribe some topical antifungal if it is coming not from an irritation, a physical irritation from the Howley. So that would be my recommendation for her overall. Overall, really, I was concerned mostly about the medication overuse headache. And she actually, as a follow up, she started to reduce the amount of NSAIDs that she was taking after I have educated her. She didn't go to see a neurologist, again, as I said, due to the insurance issue, but she is more aware now that it is harmful to continue to take the Voltafast uh, continuously like this due to multiple reasons, whether for the headache or whether their effect on the liver and kidneys and the stomach and all of the effects that we know that comes with the chronic use of NSAIDs. So she is slowly getting out of it and drinking more water and reducing her stress. Hopefully, that will help her to get out of that problem. In reviewing the literature, I looked at the headache characteristics in MS patients. I found one study by Laminta in 2011. It says that tension type headache and migraine without aura are the most common primary headaches reported in MS patients. Another study by Beckman in 2019, he found that the prevalence of headache among all multiple sclerosis patients was 68% in his study. And interestingly, that medication overuse headache was far more prevalent in MS patients than in previously reported community population, just like our patient here. So this study really fits perfectly with our patient with her medication overuse headache. And another study by Winstock in 2013, he was talking about the different emerging therapies that are coming for MS that are used as a disease modifying therapies, like the intramuscular interferons and subcutaneous medications that are used to help those patients, and also about some recently two new oral DMTs that were FDA approved for the treatment of the remitting relapsing MS, like our patient here, which are the Obagio and Tesvidera, and as well as some other monoclonal antibodies that are showing good beneficial results in the relapsing MS. So again, we all know that these are options available for the patients, but unfortunately our patient is not able to take them, and seems that mostly she's not getting the attacks as frequent. It's been 8 9 months since her last attack, and this is very good. And mostly her problem is the bruxism and the headache, and as I mentioned before, how I'm planning to manage those for her. And that's all. Thank you very much.